I believe we should be live.
Great.
Just waiting the final confirmation. All right. Good afternoon. This is American Surgery Center. My name is Kemal Erkan. I'm the chairman of Surgery Center, American Surgery Center, as well as United Medical ACO. As usual, today our weekly event, 3 p.m. Wednesday, and I have Dr. Irgau with me, and I'm going to ask him to introduce himself, and then we'll start our session.
Thank you very much, Kemal. Good afternoon, everyone. I am Dr. Irgau. I am the president of the Christiana Institute of Advanced Surgery, or CHRIAS. My specialty is weight loss surgery or bariatric surgery, and I have been performing bariatric surgery now for almost 20 years. I belong to a practice, the CHRIAS, that specializes on weight loss surgery, and it has by far the most experience when it comes to weight loss surgery in our area. We have really started and implemented programs in bariatric surgery in our area's main hospitals for many years now. Very happy to be here. Good afternoon again, everybody.
All right, thank you, Dr. Irgau. So I'm going to go ahead and introduce our other surgeons as well.
Yep.
We have Dr. Gail Wynn, Dr. Michael Peters, Dr. Rahul Singh, Dr. George Ibrahim on the bariatric surgery side. We do have a colorectal surgeon, Dr. Sachin Vaid, and our surgical PA, Sydney, is also part of our surgical team. And for the bariatric program, the nutrition is one of the most important pieces. So we have 3 full-time nutritionists with us, Amy, Beth, and Fran. I do need to make a correction, 2.7 full-time because Amy is not full-time. So our nutritionists are making this experience a lot easier for our patients. And now, just so that we want to make this easier for our patients, when we do these sessions, we try to keep it under 30 minutes. And everyone can actually see in a small portions what this is and what's going to happen throughout the surgery. And today we are going to do the what to expect on the day of the surgery. So just to remember what qualifies for bariatric surgery, 18 years minimum, you need to be over 100 pounds from your body mass index, which is like 40 or greater, or if it's under 40, between 35 and 39.9, you need to have one of the 4 illnesses. These are high blood pressure, type 2 diabetes, heart disease, and sleep apnea. So now, as a group, we have done more than 10,000 bariatric surgeries. We also do general surgeries, obviously. In the last 3 years, the total number is 2,000. Now, in our total numbers, it may actually go down. In the last couple of years, we do this because we are specializing in the outpatient surgery center, which requires us to be more focused on each patient on an individual level. And therefore, we actually added care coordinators, care managers as part of our team. And at this point, for us, it's not about the total number, but the patient experience that we are able to provide. And that's our main focus with our team. Now, Dr. Irgau, of course, some of these informations our patients can find out from our websites, but just to kind of make some of these things a little bit easier, the preparation for the day of the surgery, if you can just walk us through what patients should be doing on that day, the day before, and then maybe we can talk a little bit after the day after the surgery.
Absolutely. Thank you, Kemal. So today we're going to be focused on the day of surgery. We're talking about the day of bariatric surgery. And most of our procedures are done, as Kemal mentioned, at the American Surgery Center. So we are going to talk about the protocol we have at the American Surgery Center. So a person who's ready to have bariatric surgery will have had a call from the American Surgery Center days ahead to let them know how they need to prepare for the surgery, for the day of surgery when they come to the surgery center. When the person arrives at the surgery center, obviously they will be checking in, but then they will be seen by the nurses for the proper admission. And at that time, they will be given medications that we utilize to prepare the patient for a fairly speedy and safe recovery. For instance, one of the things that traditionally surgeons are used to talk about is that pain medication is given to a patient when the patient has pain, right? You have discomfort, you let your doctor or your caregiver, your nurses know, and you're given pain medication. Well, that used to be the way we did it in the old times. Now we really have a very different view of pain control. We believe that pain control is essential for a speedy recovery because we want the person to have relatively less pain so that they can be up and about early after surgery. One of the ways for achieving this is actually to preemptively administer some specific pain medications before the surgery. And these pain medications actually will prime the body to have less discomfort after the surgery. So our nurses will actually provide those medications ahead of the surgery. So you haven't had the surgery yet, and yet you will be given medications. But interestingly, these medications are not narcotic medications. These are not the medications that will make the person feel sleepy, that will mess up with the head of the person, that they will slow down the recovery of the digestive tract. These medications do not have any narcotics in them, but they are given preemptively, as I said, and they will make the person much less vulnerable to pain after the surgery. An additional medication that will be given by our nurses before the surgery, again, is a powerful medication that we have available only at the surgery center. Thank you, Kemal. Which allows our patients actually to have less nausea after surgery. Now, as you know, nausea is a fairly common thing that happens after anesthesia. If you've had surgery before, whatever type of surgery, just the anesthetic will have caused some nausea for most people. And then the surgery that we do, the bariatric surgery, which is undertaken on the digestive tract, actually by itself can cause nausea as well. So controlling nausea, controlling this urge to want to be sick is very, very important for, again, a speedy recovery. Well, we have this powerful medication, as I said, that we just have available at the surgery center that the nurses will be administering to the person again before the surgery. So we are working in a preemptive manner. We are preventing, we're minimizing the potential issues from the get-go. Another medication that the patients will have, again, before the surgery, is a medication to minimize the risk of blood clots. As we know, blood clots are one of the potential risk complications of any type of surgery, but also of bariatric surgery as well. The best way to take care of that is to prevent it. And one of the ways we prevent this is by giving this blood thinning medication, which is given again ahead of the time by our nurses as the patient is preparing for the surgery. So all these preparations will occur to really influence the recovery of the person, to make the recovery faster for the person. For the person will have less nausea, less discomfort, and also less risk of blood clots afterwards. The anesthesia people will be seeing the patients. Yeah, of course.
About the nausea and the bleeding, and we discussed this last week, that many people don't know the difference between ibuprofen and Tylenol, and including myself, maybe until last year. So when we say painkiller, we put the Advil, ibuprofen, and Tylenol in the same group for non-clinicians. Can you talk about that a little bit and then just explain the difference?
Absolutely. So Tylenol is a medication that acts in a certain way in our body, and something like ibuprofen or Advil acts in a different way, right? Now, this medication is, both of them do not have any narcotics of them. So this is a welcome thing for us because we're trying to minimize the use of narcotics. Of course, when narcotics are essential, we obviously can administer them and they're available to us. But if we can minimize their utilization around the time of surgery, it really enhances the recovery of our patients. So both Tylenol and ibuprofen are different and they can be complementary, right? But also they have different potential side effects. For instance, Motrin belongs to a class of medications known as non-steroidal anti-inflammatory drugs. And these medications actually can cause upset of the stomach, but sometimes can make the function of a cell that we have that we call platelet. They can interfere with that function, and platelets are very important in preventing bleeding. So if we provide too much of this medication, obviously bleeding could be a risk. So what we do is, by providing these different types of medications in moderate amounts, and because they work in a complementary fashion, we're able to control pain without exaggerating the potential side effects of these medications. So you are right, these are different medications. And as I say, we use them in a very smart way before the surgery, but also after the surgery to minimize discomfort.
Yeah, I think what's important from the patient standpoint, we have so many different providers or different checkpoints. We have from the surgeon to the nutritionist to the other specialties who are part of it. But when it comes close to the surgery date, our facility actually reaches out to the patients at least 2 weeks before, and then a couple of days before again. Those conversations are extremely important. So listening exactly what you need to be doing with the checklist. We do provide all these, but I think we do need to pay a little bit extra attention in terms of what's okay and what's not okay to do, the do's and don'ts, because that's going to make this a lot less complicated, because something small can cause unnecessary complication. And because there are so many different people who are helping, what we expect from our patients to listen to each provider's instructions that's given to them, and then make sure that you also have someone with you, obviously a family member or a friend who's going to be able to stay during the time of the surgery and after during the recovery time. Now, the operation, for our patients to know, how long does it take for gastric sleeve versus gastric bypass?
So essentially, both procedures are done laparoscopically, which means with small incisions. All the personnel that we have at the American Surgery Center, all of them are experienced in taking care of bariatric patients. We can actually call the American Surgery Center as a surgery center that really specializes in bariatric surgery, because that's the bulk of the surgery that we do. As I say, the surgery is done with small incisions, usually about 4 or 5 very small incisions. And the surgery itself typically takes about an hour, maybe an hour and 15 minutes. The sleeve gastrectomy takes a little bit less than the gastric bypass. So if the sleeve gastrectomy takes about an hour, the gastric bypass may take about an hour and a half. Both of them really within a relatively short period of time. Once the surgery is done, the person will go to our recovery area. And what is very, very particular about our surgery center is that that person will be recovering under the observation or watch of a nurse. So there will be one nurse per patient, which is really a luxury that we have at the surgery center because of the setup, which is not something that you can find very easily in other places. So the patient will have that one nurse really recovering with them. As I said, our whole protocol is really to get this enhanced recovery. So the person will actually start getting up and walking within about an hour and a half, maximum 2 hours after the surgery. And they will be starting to take sips of liquids also very early. So this is possible because the protocol itself really lends to the patient having less discomfort, less nausea, and quicker awareness because of the decreased utilization of narcotic medications, which usually suppress the patient's alertness. And this is what makes the surgery center very special. This is what makes it so appealing also for us surgeons, because we know that if we can get a patient up and about early, that also helps us minimize complications. If the patient is up and about and they are breathing, expanding their lungs, well, that will minimize the risk of things like pneumonia. If the patient is up and about early, that will minimize the risk of blood clots. If the patient is up and about early, that will take away the need for catheters and other things which we used to use in the past, essentially. And then, as I said, the safety profile as well. You know, you're being monitored, and there is this one nurse per patient who's going to be there just observing that patient. So it's a setup really that is very conducive, not only to high level of safety because of the setup, but also early recovery, as I said. And typically patients will be going home within about 6 to 8 hours after the surgery. And of course, before they go home, they will have to have been able to be up and about. They will have to be fully awake. They will have to have very good control of discomfort or nausea, and being able to drink fluids as well. So that's really the typical expectation. Of course, the preparation for the surgery, as we talked before, is extensive, because to get to that level of efficiency in what we do, we have to get a patient who is really well prepared and motivated. And the preparation before surgery with the care coordinator, with the nutritionist and the other specialists that we send the patients to, allows us really to be able to accomplish this.
So, Dr. Erkan, from the patient standpoint again, would well, because I know the answer, so I can fake it. So I'm just gonna have the conversation. So in what circumstances we may have a different surgeon on the day of the surgery?
Absolutely. So as you mentioned earlier on, there is 5 bariatric surgeons at CHRIAS, and essentially all of us pretty much do the surgeries in very, very similar ways. We can complement each other's work without any problem. So there are situations, for instance, in which a patient is scheduled to have a surgery with a particular surgeon, but that surgeon may not be able to be there because they have a family emergency, or they're not feeling well or something. Well, we don't cancel the surgery. One other surgeon, or provided the patient is comfortable with that, will step in and be able to do the surgery. And that has happened in the past, obviously not always, but it can happen. And it's really a good, a comforting thing to know that all surgeons are really well trained and very experienced and versatile, and also know exactly how the surgery is done, to step in to take the position of one of their colleagues if that colleague is not present that day.
Sure. And would I have a resident do the surgery or be part of the surgery?
So you won't. So the American Surgery Center obviously does not have trainees. So the surgery will be performed by the surgeon themselves. So it's not a teaching place. So there's not going to be other people that need to practice on doing the surgery so they can teaching institution. So the surgery will be fully performed by the attending surgeon, by one of our bariatric surgeons.
So, Dr. if you don't mind me asking, utilization of the residents used to be for uninsured population in the recent days, until the recent days. But I think the utilization of residents now is larger, even for the fully insured patients. This may be happening. So the reason I was asking, having residents in the surgery, of course, if we were a teaching institution, it's important, but it's also not for every patient. So, like, I wouldn't want to have a resident on my surgery if I'm getting the surgery, or if my mom is getting the surgery. I would want the best, most experienced surgeon being fully in charge of that. And I think for patients to know what we actually utilize, who we utilize, is important. So in this place, surgeon is fully in charge from the start to the end. We do have a surgical PA on top of our other staff who are required in the OR. But I think, as you mentioned, the most important part is, one of the really important part is recovery nurse. In our PACU area, we call the recovery is extremely important, but who's there with you during that recovery is one of our many nurses who are 90% doing bariatric. So what makes someone better in a clinical setting is how many times they repeat same type of tasks. This may be a surgeon doing more surgery, the nurse doing more recovery, with number of patients, and then as they see different variety of what the outcome, then they will be more experienced for the next. And I think one of the reasons that we were able to achieve almost 100% patient satisfaction, Dr. Guy jinxed this one a little bit. There was one patient that had some other issues not related to this facility, but anyway, so right now we are 99.2%. So this is about 123 total responses that I received from our patients, and getting to this 99.2% ratio is not it's not easy, and we weren't just lucky. We worked for it, and having the team on our side, on our patient side, the care coordinators, facility and practice nurses, staff, nutritionists, psychologists, surgeons, the other specialties. This just makes the multidisciplinary approach the absolute success story for our patients, and we want to make sure that everyone who's going through the surgery understands that we'll be there throughout the process. And because this doesn't stop at that point anyway, so this is the beginning of the new life after the surgery. Last couple of weeks, actually, we discussed a couple of patients. After their 6 months, they have lost each 100 pounds, close to 100 pounds. Yep. And that's a brand new life. So now we have wellness part of it starts, and we try to support our patients after that. Now, Dr. Irgau, anything on the telemedicine side, how that helps the preparation, or because we don't see the patients as often as we did in person, how do we overcome those issues just for the preparation for the surgery?
Absolutely. I think it's important to understand that although telemedicine has been extremely important for us and has facilitated the interaction between us and the patients, we have to understand that it has limitations as well. Clearly, in this day and age of the pandemic, we are trying to minimize interaction. And but even with that, we do want to see our patients, in person at least once through the process. A fair amount of the information that we need to discuss the eligibility for bariatric surgery, the understanding of bariatric surgery on the patient's side can be done through telemedicine. There's no question about that. Also, because we do get a fair amount of information from other medical records also to give us a complete picture of the patient's health history. Having said that, that personal interaction is important, and our program obviously insists on that, so that obviously in times in which the pandemic was very, very tight, it was very difficult to put this in practice just because we wanted to be socially responsible as well. But now that things are a little bit less tight from that point of view, we do get patients to come and see us in person for that personal interaction, but also for us to be able to assess certain things that cannot be easily assessed via telehealth. For instance, we like to see the back of the mouth of patients to assess how easy or difficult it is for them to have general anesthesia. It's an information that our anesthesiologists want us to record on our chart, and that sometimes can be done through telehealth, but it is really best done on a close physical examination as well.
I do want to just remind everyone that with the telemedicine, the patient portal, utilization of patient portal has become more important for all of us, providers and patients and staff. So you can download the application. It's pretty simple. We have all the instructions on our website, but without having access to your own chart, I think the patients would be missing out on the opportunity, because interactions these days, how many times you have to call the office, or for what reasons you need to call the office, wait time and all that other stuff can be eliminated very easily by using the portal. And also this helps for our telemedicine visits. So now it makes it even more important for us to use the portal. So I do want to remind our patients to be mindful of that. Now, the other thing is, again, with these events that we have done for the last year, our standard weekly events or monthly events or bi-monthly events are now pretty set. This event on Wednesday is 3 p.m. Our weight loss webinars, which we actually go into more details on those. That's every second and fourth Tuesday, 6 p.m. And then the recent updates from COVID and other ACO-related issues, I cover those on Fridays at noon. And one of them is going to be this Wednesday tonight, Wednesday wellness webinars, second and fourth Wednesday at 7 p.m. So these are pretty much standard events that now we have. You can find everything on our channels without any issues, any difficulties. I think getting ready for the surgery is really important, and taking that to the next level and doing the surgery is even more important. We'll discuss the dropout rates, ratios for our next sessions, but many people, since we start doing this at the level that we do from the surgery center, our dropout ratio actually did decrease tremendously, actually. So many patients were dropping out very quickly, but with us putting this much effort and support out there, now many more patients are with the program, and we are very happy with that. So, Dr. Erkan, anything that you would like to say before?
Yeah, so I just want to add, Kemal, that, at the American Surgery Center, we have achieved something that really is very, very important for our community, and that is a highly specialized, well-run, very, very safe, high quality surgery center for bariatric surgery. And this has been possible because there has been this great cooperation between a set of extremely experienced bariatric surgeons and a very, very experienced and smart business side to run the surgery center and allow us to have the structure that we need so that can be placed that could be in place. And that's why we have the results that we have. That's why we have the satisfaction of patients that we have. Clearly, as you mentioned earlier on, Kemal, we are not a teaching center, so we do not have residents, obviously. There is a place for residents, of course, for teaching, and the hospitals are the main place for doing that. And when there are procedures that require being in hospital, or patients who have health issues that require to be operated in a hospital, obviously the hospital is the best setup to have there. And the presence of the trainee doctors of the residents is very important in the care of patients. And of course, even the teaching surgeons in the hospitals, obviously, even if the residents have a part in that operation, will be supervising the residents very, very closely, particularly in the critical parts of the surgery, so that safety profile is obviously within the hospital as well. But we, as a matter of fact, we're not a teaching center at the surgery center, and that's why we don't have the residents. But in terms of really advancing the quality of bariatric care, the surgery center really has pushed the envelope in our community, and I'm extremely proud for that.
Well, Dr. Irgau, it's a pleasure for me to be also part of the program. As you mentioned, the discipline that we have, daily case conferences, our experience, our background, it made it possible for us to be able to provide what we have. So thank you for being with me, and we'll be back next week, same time. And then tonight we have our diabetes events. Any of our patients who may be dealing with diabetes, we have Dr. Ripu Handal at 7 p.m. He's going to be with us, and otherwise we'll see you next week. Thank you so much.